Hello, good afternoon. Welcome. I'm Janet Gatlin with Rogers Behavioral Health. I'm so glad that you were able to join us today to celebrate our International OCD Awareness Week, coordinated with International OCD Foundation. OCD Awareness Week takes place this week. It's the second full week in October. With events all across the country to support and advocate and educate about reality of OCD to break up the stigma surrounding it. Today, we welcome Dr. Jennifer Park and Dr. Tarik Hadzic to talk about sexual orientation, OCD, and gender identity in OCD. Before we get started with today's webinar, I'd like the participants to give a quick overview of the format. The webinar today will be scheduled for 90 minutes. To receive receive the CE credits, you must be logged into the webinar for the entire program. Your attendance is going to be tracked via Zoom login and logout records. A PDF of the PowerPoint slides and a list of references will be available immediately after the program via the email link to your personal dashboard at cego.com. In addition to the recording of the webinar, will be published on Rogers' YouTube channel within the next day for you to rewatch. Our speakers will be presenting today between 70 to 75 minutes, and then follow the presentation, we will be hosting a Q&A session. If you'd like to ask our speakers a question, please use the Q&A button at the, not the chat button, to send a message. That is at the bottom of your screen. You simply click the Q&A button on the Zoom taskbar. We will review all the questions as submitted, and then the presenters will be addressing any of the Q&A questions at the end of this webinar today. Finally, we have enabled the caption for the program at the bottom of your screen. There will be a live transcription button from your menu. You could click the show subtitles to view the audio as the text. If you'd like to disable the subtitles, simply click hide the subtitles from the live transcription menu. Now I'm going to go ahead and turn it over to our presenters today. Thank you.
Thank you, Janet. So Dr. Hadzic and I, we do not have any disclosures to declare at this time. Here's an overview of what we'll be covering in this webinar today. We'll be reviewing sexual orientation and gender identity OCD, differential and diagnosis, treatment, and then, as Janet mentioned, we'll also be having a moderated Q&A. Here are some of our learning objectives for today's webinar and CE event. And just as a quick overview of myself and introduction, my name is Dr. Jennifer Park. I am a licensed clinical psychologist. I am the Executive Director of Clinical Services at Rogers Behavioral Health. I consider myself to be a clinician, a clinical supervisor, as well as a researcher. I go by she, her, hers pronouns. I am Korean American, and I am married with one child, my 2-year-old son.
And I am Dr. Hadzic. I'm a child, adolescent, and adult psychiatrist. I have an MD, and I also have a PhD in genetics and neuroscience. And at Rogers, I see patients, so I'm a staff psychiatrist. I'm also an assistant medical director for Rogers in California. And I still am interested and do some research. My pronouns are he, him, and I consider myself Bosnian American. I'm a cisgendered man, and I am single.
And so now we're going to be talking about sexual orientation and gender identity OCD. So something to note is that OCD, obsessive-compulsive disorder, is a multifaceted and heterogeneous disorder. And what that means is that it can present in many different ways. So what you might see in an individual with OCD, or have two individuals with OCD in front of you, they can present very differently in terms of the intrusive thoughts and the obsessions that they might be reporting, as well as the compulsions, safety behaviors, maybe avoidance behaviors that they might be engaging in. They can look very, very different. And because OCD is such a heterogeneous disorder, this can be challenging at times for professionals, who may not have a lot of experience with OCD to be able to identify it as such. The heterogeneous nature of OCD has been well researched, and researchers have noted that there are certain categories or factors, or what we call symptom dimensions of OCD, so large groupings of OCD presentations that come together. There are 4 factors that have been identified. One of the factors is forbidden thoughts. This includes aggressive OCD symptoms. So this includes fear of harm towards self or fear of harm towards others, sexual OCD thoughts, and that can be related to fear of engaging in unwanted sexual behavior, more aggressive sexual thoughts such as like rape or pedophilia. This can also include sexual orientation OCD as well. This factor also includes religious obsessions, somatic obsessions, as well as checking compulsions. The other symptom dimension is that of symmetry. So symmetry, obsessions, and repeating. So lining things up, wanting things to look a certain way, ordering and counting compulsions. A third category or symptom dimension is the one that many people are most aware of. These are our cleaning OCD symptoms, or contamination obsessions and cleaning compulsions and rituals. And finally, the last factor being hoarding obsessions and compulsions. So as I noted before, the sexual orientation OCD does fall under the forbidden thoughts subtype. But it's also included in that subtype, as I noted, are a lot of different other types of categories and a lot of different types of symptom presentations. Sexual orientation OCD has historically been labeled as homosexual OCD. This is something that you might see in the literature or in research articles in the past, as identified as HOCD. In more recent years, this has been changed to sexual orientation OCD to be more inclusive. Sexual orientation OCD really presents as significant pathological doubts about one's sexual orientation. And so this could be fears of being or becoming gay, lesbian, or queer, or even fears that others may think that one is gay, lesbian, or queer. But it can actually go both ways as well. It's not just about becoming or fearing becoming gay, lesbian, or queer. Somebody who might identify as gay or lesbian may have sexual orientation or OCD where they may question, am I actually gay? Maybe I'm straight. So it can go both ways as well. In regards to sexual orientation OCD, the prevalence of it does need a little bit more investigation. Part of that is because the symptom dimension that it's encompassed in, as I noted, has a lot of different types of symptom presentations. It's not just sexual orientation OCD or gender identity OCD. And so about 30% with OCD do report these types of sexual or religious obsessions, but we're not really quite sure exactly what percentage within that is specifically related to sexual orientation OCD or gender identity OCD. 12% of those with OCD do report lifetime presence of sexual orientation OCD obsessions. And so this does tell us that it is fairly prevalent from the information that we have at this time. In regards to gender identity OCD, this is something that is a little bit less known. However, anecdotally, this is increasing in prevalence in our clinics and just patient presentation as a whole. Gender identity OCD is related to fears of being or becoming transgender, or fears of uncertainty related to gender identity. And again, it doesn't really discriminate in regards to what type of community it can present in. So it can present in those who are heterosexual, as well as those who may have be part of the sexual minority group. One of the ideas behind gender identity OCD, as well as sexual orientation OCD, is that it's theorized that obsessions can be more likely to develop when stigma is greater. So when things are considered either stigmatized or maybe something that may seem very taboo, this can kind of create a situation in which obsessive fears or intrusive thoughts may develop. So it makes sense in terms of sexual orientation OCD as well as gender identity OCD, as sexual minorities have been historically stigmatized as a group overall. These both sexual minorities and gender identity minorities have been marginalized over the decades. And so again, in terms of being an area in which OCD can really flourish and hold on to these kinds of thoughts and fears, it makes a lot of sense. Another idea in relation to the theory of the development or increase of gender identity OCD is this idea that the more that these types of things are brought forward into public discourse or public scrutiny, the more that things that it's talked about in social media or news, this may increase someone's either fear, awareness of this particular topic, and latching onto these ideas and these thoughts. One of the things that we've noticed is during the COVID pandemic was an increase of contamination fears. So that's one way in which these kinds of things can occur. Also during the time of the pandemic, when the Black Lives Matter movement was occurring, there was an increase of individuals with OCD who presented with fears of being perceived as white supremacists or even considered Trump supporters. We've also seen recently fears of being canceled. So individuals who come in who say, what if I do the wrong thing and people turn against me and I'm canceled? And relatedly, the fears of being transgender. So again, this is something that's being talked about in the news all the time. It's talked about in politics. There's a lot of laws, regulations that are coming out and a lot of public discourse that is occurring. And so the fears of being transgender or gender identity OCD, we have seen an increase of prevalence, again, from an anecdotal perspective. In the past decade, we have also seen that there have been a doubling of estimates of those who identify as gender diverse. So people who may consider themselves gender non-binary or transgender, just in everyday life may be a little bit more present. And that is something that people may be noticing as well. And finally, gender identity may be considered more taboo than sexual orientation. The idea of gender incongruence is something that continues to be hotly debated amongst a lot of different groups. And so because of that, the idea that this is something that may not be okay or maybe something that could be feared is something that may increase or lead to an increase in OCD symptoms. In terms of the presentation of sexual orientation OCD and gender identity OCD, I think something that's really important to note is the high levels of distress that occur in these two types of presentations. For sexual orientation OCD, in a study, we found that there were 91% of individuals who reported high levels of distress. And from those individuals, 21% reported suicidal levels of distress, so very extreme distress. For gender identity OCD, while we don't have studies that can really look at the overview of how distressing these symptoms may present for individuals, there have been case studies that have been published that have described gender identity intrusive thoughts as inducing intense fear that was described as paralyzing. So again, highlighting that extreme distress. Now, shifting gears just slightly and going in a slightly different direction, we want to talk about the presentation of OCD in LGBTQ plus populations as a whole. Now, this is something that's a pretty under-researched area, but there have been a couple of studies that have come up quite recently. So one of them, published by Dr. Pinciotti and Orcutt in 2021, examined OCD symptoms in those who identified as lesbian, gay, or bisexual. And what they found is that amongst these individuals, that sexual minorities reported significantly greater OCD-related unacceptable thoughts related to violence, sex, or religion. And it's important that this was also controlled for trauma and post-traumatic symptoms, as we do know that trauma experiences may be higher in this population as well. Another very interesting point to note is that sexual minorities were more likely to exceed clinical cutoffs for probable OCD. Dr. Pinciotti also published a paper in 2022 looking at gender minorities. And she examined patients that were in specialty OCD treatment programming at higher level of care. And by examining these individuals, 1.7% of 974 patients identified as a gender minority. And what we found is, or what she found is that those who identified as a gender minority experienced attenuated treatment responses. And more specifically, these individuals required longer lengths of stay, and only comparable benefit to treatment in certain OCD symptom dimensions. So treatment response was not the same all across symptom dimensions. It depended on how the OCD presented overall. In this population, they also found more severe contamination symptoms, as well as increased rates of comorbid disorders, such as substance use disorders, personality disorders, as well as trauma-related disorders. Dr. Hadzic?
Yeah, so and I will today discuss some common sources of misidentification by professionals. So when a patient comes to a clinician, it's important that they get the right diagnosis, because the right diagnosis will lead to correct treatment. And when a patient with gender issues sees a clinician, there are a variety of factors that are at play that could be affecting correct diagnosis and therefore correct treatment for any patient. I like to divide these factors into intrinsic factors, clinician factors, and then patient factors that are also related to stigma. And for each disorder, so in this case, OCD, with a gender theme, gender doubt, and gender incongruence, which is the preferred term currently over gender dysphoria, I have outlined some factors, and I will go over these factors on subsequent slides as well, but this table lists roughly the overview. Intrinsic factors are those factors that I consider intrinsic to the diagnostic construct at hand. And for each of the two different diagnoses, the factors are different. Clinician factors are those factors that affect clinicians, and they can include implicit bias or other sorts of biases, personal experience, and professional training. And finally, patient factors are those factors that are related to the patient's willingness to share their symptoms. And therefore, stigma must be considered as an important part of this. Next slide, please. So diagnostic difficulties, if we start with OCD in general. So professionals are more likely to have difficulty identifying sexual themed obsessions due to doubt-based OCD being more difficult to diagnose. So by extension, because data are sparse, we believe that there's even probably more difficulty identifying gender-themed obsessions in patients with doubt-based OCD. And it's also a known fact that even seasoned clinicians may struggle with the diagnosis of doubt-based OCD. There are a variety of reasons for this, but avoidance and need to conceal are probably more salient due to the shame behind sexual orientation and gender-based themes. As far as intrinsic factors for gender incongruence, this diagnostic category is evolving, and we have an evolving understanding of gender incongruence, and as well as complexity and treatment outcomes. Next slide, please. As far as clinician factors, I will first discuss clinician bias with respect to gender incongruence. So there are still clinicians in this country and around the world who do believe that gender identity is purely a social construct that can easily be influenced or changed. By now we know, based on solid studies, that this is not something that's easily changed. And moreover, non-factual beliefs that gender identity can be externally reversed are a significant source of bias when clinicians approach these patients. There are now several studies showing that gender identity persists in majority of cases. This is also known as the persistence versus desistance debate. But there are studies from multiple countries around the world showing a persistence of gender identity. As far as OCD clinician factors, so gender OCD, there is a reluctance to obtain shame and taboo themed histories, especially if it's the first time you're examining or meeting a patient, because frequently we try to build rapport with patients, and it's difficult to ask some of these very shame, what the patient perceives as shame, or an intimate question within the first meeting or even first couple of meetings. Next slide, please. And then as far as patient factors, stigma is a significant factor to consider. So for gender OCD patients, they frequently sense a lot of stigma when they're reporting intrusive thoughts of doubting their own gender. And this can go both ways. So it can go for cisgendered patients where the identified gender matches the assigned gender at birth. And it can also happen to patients who are transgendered or gender nonconforming as well. There are also issues with clinicians inquiring about taboo type thoughts, leading to reluctance to obtain more history about these thoughts. And then, so that those would kind of be factors specific to patients with gender OCD. As far as patient factors pertaining to gender incongruence patients, this is a highly vulnerable population, and they are exposed to social and cultural discrimination and violence due to identifying with a gender other than the one assigned to them at birth. And therefore, there's a lot of stigma and fear associated with being open with clinicians about this. And another source of stigma is actually clinicians perpetuating the gender stigma with transphobic or discriminatory behavior against gender incongruent patients. And there are documented cases of this through a variety of healthcare and healthcare related professions. Next slide, please. So in summary, the misidentification can happen in both ways. And as I'll explain, this goes back to the beginning of my section where I was talking about correct diagnosis leading to correct treatment. So misidentification of a gender OCD patient for gender dysphoria or gender incongruence, which is the new preferred term, but DSM-5 still calls it gender dysphoria, leads to negative consequences, particularly treatment delay, potentially worsening symptom severity, and even further stigmatization if OCD is diagnosed as gender dysphoria. And the corollary is misidentification of gender incongruence for gender OCD may lead to grave consequences in a very vulnerable population with higher rates of depression, suicidal ideation, and suicide attempts. So this is a particular area of concern. And I do think that today's talk is very important to try to reduce that. Next slide.
All right, so I'll be talking about differentials and diagnoses. So starting off with sexual orientation development. So this would be more like normative sexual orientation development. We're not talking about sexual orientation OCD. And when we talk about sexual orientation identity development, uncertainty is considered a very normative part of development as a whole. So uncertainty, like, am I gay? Am I straight? Those kinds of questions. Again, this is for both heterosexual and sexual minority groups. It is very normal to go through these stages of questioning. It reflects normal curiosity and exploration. This can be reflected through sexual experimentation, maybe through fantasies, and kind of thinking through different types of sexual attraction and ideas in one's head. So again, this can be very, very normal if an individual goes through this. Another part that can occur in normative sexual orientation development is when uncertainty is quite high, and that uncertainty is experienced as distressing. And I think Dr. Hadzic did a really nice job of talking about why it might be distressing in these types of groups that individuals may experience or may think of things as they may have a potentially adverse reaction to being part of a highly stigmatized minority group. As you noted, there's a lot of social and cultural discrimination that continues to exist, very real violence that can occur in these groups. And it makes sense where people may have a distressing response to the uncertainty that they may experience through their sexual orientation development. For those who have higher sexual orientation uncertainty, and again, this is not within those who have sexual orientation OCD, so this is outside of that, higher uncertainty is associated with increased depressive symptoms, stress, and rumination. And again, it's in both groups, both in heterosexual individuals as well as those who are sexual minorities. However, a study has also shown that aggression being operationalized as a recent instance of physical and verbal aggression or increased anger and hostility, that aggression was only predicted in sexual minorities. So when there was increased uncertainty, this would predict aggression in only sexual minority groups. And this can be hypothesized that this may be related to fear of sexual minorities, of fears of discrimination, or maybe even recent experiences of discrimination that may lead to these increased instances of aggression. What has also been identified is rumination as a common maladaptive coping strategy for those who have high sexual orientation uncertainty. It's important to note that in sexual minorities, rumination was also mediated sexual orientation uncertainty and psychological distress. So those variables are very highly related to one another. When talking about gender identity development, gender dysphoria or gender incongruence oftentimes manifests in early childhood. So an individual's ability to identify that, hey, maybe my biological sex is not aligned with how I feel and how I see myself, that oftentimes occurs in early childhood. There are multiple theories of stages of development in regards to gender identity, but with these theories in general, there are a couple categories that kind of come out as themes that individuals may go through in terms of their stages of development. It starts off with anxiety, so gender discomfort that's related to their gender incongruence when they start to identify that incongruence exists. Confusion related to doubts of their biological gender, doubts of authenticity of their own transgenderism. Then they might experience exploration, so testing their transgender identity, seeing whether or not they feel good doing different things or acting different ways, wearing different clothes. And then in terms of acceptance, so acceptance of the identity. So this is a place in which we want individuals to eventually get towards in regards to their gender identity development. And finally, and the authors do identify this as an ideal state, a state of the development stage of pride, where they can take pride in their gender identity and really be able to live their authentic selves. It's also important to note that gender identity misclassification is defined by the experience of not having one's social identity affirmed correctly by others, that this actually leads to increased negative emotions and feelings of threat. For those who may experience gender identity affirmation, they report feelings of being in control and decreased anxiety and depressive symptoms. And this is important to note when we're talking about or trying to differentiate between normative gender identity development versus gender identity OCD. So as a professional, when you are presented with an individual who may have sexual orientation OCD or who may have gender identity OCD, there are certain areas of assessment that you can consider. Of course, getting a thorough background is very important for any client who may walk in the door. But in this particular situation, it is very important so that you can get a good sense of what their views are. What are their family views? What's the stigma that might be attached to these categories of whether it's sexual orientation or gender identity? How do their families feel about this? What are their values? What do their relationships look like? How about their cultural background? What about their social community? Is this accepting? Is it not? What would it mean to them as an individual if they were gay or lesbian, or if they were transgender or non-binary? How would that impact their individual lives, regardless if they did not have OCD? What would that mean? Another way to assess for OCD is, of course, our gold standard assessment method, which is the Yale-Brown Obsessive Compulsive Scale, or the Children's Yale-Brown Obsessive Compulsive Scale, which is the child version of the Y box. And what's important to note when administering the Y box and the Psi box is that uncertainty and distress can be present in both normative development as well as OCD. So it's going to be important to be able to differentiate between that. The presence of distress, the presence of uncertainty does not automatically indicate OCD. Through the Y box or the Psi box, you can assess for severity of distress and impairment, as well as presence of other OCD symptoms, lifetime or current. And that's fairly important when we're trying to assess for somebody who might have, trying to assess a differential of OCD. One of the things that I often look at is I say, are there other types of OCD symptoms? Has this patient ever had any other types of OCD symptoms, maybe outside of potential sexual orientation or gender identity OCD, maybe something more classic like checking or cleaning? And those are things that can be kind of markers that help us say, hey, you know what, this could potentially be OCD because this individual already has a history of OCD. Other things to also consider is whether or not these feelings are ego dystonic or ego syntonic. Now, we do have to be careful about this because, again, as Dr. Hadzic very nicely articulated, those who may identify as gender non-binary or transgender or gay or lesbian or bisexual, these are groups that have been heavily stigmatized, that have experienced a lot of discrimination. And because of that, they may experience ego dystonic sort of experiences during their development while they're trying to sort out, is this, what is my sexual orientation? What is my true gender identity? So these are things that may occur. However, outside of this, there are those, those who may experience more normative development. They may experience moments where thoughts of affirming gender or being with same-sex individual may actually provide some comfort or relief. Whereas in OCD, you do not see that. Oftentimes you do not see that. It's almost always marked by negative affect or ego dystonic distress, and related compulsive behaviors. So again, when we're thinking about the assessment of an individual and trying to determine, is this OCD or is it something else? One of the ways in which we can do this is really being able to do more of a precise and sensitive functional analysis. We want to see what kind of behaviors is the individual engaging in when they have thoughts of being gay or when they have thoughts of being transgender. Are there certain behaviors that they engage in at that time, certain emotions or distress that they might experience? And then when they do engage in said behaviors, what is the function of said behavior? How do they feel afterwards? What are the consequences of that? Now, what I have here on this slide is a kind of classic OCD CBT model. And what it highlights is that when the obsession occurs, the obsession leads to increased distress and anxiety. And an individual with OCD will then engage in a compulsion or a ritualized behavior. And the function of that behavior is to decrease distress and anxiety, to create temporary relief from distress and anxiety. And this is a negative reinforcement cycle. So again, as I noted, this is our CBT model of OCD. And one of the questions that as a professional we can ask ourselves is, okay, when we do a functional analysis, when we really break down the thoughts and the behaviors and the emotions, does it map onto this model? Has it created a negative reinforcement cycle? And that can help indicate to us that potentially the way that this individual may be presenting or not presenting is related to OCD. Another way in which we can assess individuals with sexual orientation OCD and gender identity OCD is to utilize the downward arrow method to identify the core fears. This is a method that is widely used in OCD treatment as a whole. And the idea behind it is to ask questions. What is your fear? What is it that you're afraid of? If that were to happen, what does that mean? And then what? And then what? And finally, really being able to distill it down to the core fear, the thing that the person is most afraid of. There is an assessment measure that was developed to be able to assess for sexual orientation OCD symptoms. It's called the Sexual Orientation Obsessions and Reactions Test, or the SORT. It is a 12-item self-report measure, and it has been evaluated to have good psychometric properties. In terms of the scores, there is a cutoff score of 10 on this measure that will help to differentiate between OCD and non-OCD sexual thoughts or sexual orientation thoughts. And then a cutoff score of 14 within OCD, which differentiates sexual orientation OCD from other subtypes. So this is a potential tool that can be used for the differential as well. This would not be a tool that we would use just on its own. But again, having that clinical assessment alongside the background information and the results from the Y box and the Psi box in functional analysis can really help paint a picture of and identify whether an individual may be suffering from OCD or if this is part of their normative development. In the SORT, we have here a couple of examples of items on the assessment itself. And the measure is broken down into two categories of items. So one being transformation fears. And some examples of that is items such as, I worry about the thoughts I am having about people of the same sex. I just need to know for sure if I am straight. I worry that other people will think that I am LGBTQ. The other category is somatic checking. I check myself to see if I'm aroused by sexual images. An unwanted sexual thought or image means I really want to do it. And moving on to treatment.
And I just wanted to let everyone know that a SORT will be included as a handout available to download afterwards along with the slides. So I will now briefly talk about pharmacotherapy plus or minus CBT for OCD, and then Dr. Park will continue delving more into ERP. So the American Psychiatric Association recommends 3 first-line treatments for OCD. And those include cognitive behavioral therapy, specifically the variety of CBT known as exposure and response prevention therapy, or ERP. Another therapy would be SSRIs alone, and SSRIs are selective serotonin reuptake inhibitors, or a combination of ERP and SSRIs. So when we look at systematic reviews and what we call meta-analyses, which are large pooled analyses of clinical trials and studies, frequently from multiple countries around the world, they show that both ERP as well as serotonin modulating medications are effective in the management of OCD. As far as first-line medications that we do use for OCD, they include primarily medications known as SSRIs, selective serotonin reuptake inhibitors, the first of which was developed in the 80s, paroxetine or Paxil, which is hardly used anymore. And meta-analyses within this group have indicated that they all work, on paper, they all work equally well for OCD. For more severe cases of OCD, or for patients of any severity who fail an SSRI, the next recommended treatment is clomipramine, which is a tricyclic antidepressant. Clomipramine in some studies has shown to have, was shown to have a stronger effect than SSRIs. And it's certainly something that I use frequently in my patients at Rogers with severe OCD. It does tend to have a higher side effect burden, but there are a few side effects in some patients. And therefore it is still very much a part of our toolkit for pharmacotherapy of OCD. And both SSRIs and clomipramine have been shown to work better than a sugar pill known as placebo in gold standard clinical trials, which are randomized, double-blinded controlled trials. As far as the SSRIs, we tend to use higher doses than the doses that were indicated as maximum recommended dose by the FDA. A lot of those trials were done in major depressive disorder, and depression and OCD, even though we use the same drug, are two different neurobiologic disorders. And therefore, we have to have a lot of discussions with patients about using a very high dose. As is the case for many other psychiatric disorders, there are partial responders or non-responders. And in those cases, we use what's known as augmentation strategies. Those are strategies that are used to augment or enhance the effect of the first-line treatment, which is an SSRI or clomipramine. Based on the evidence, the first-line most effective type of augmentation includes the dreaded antipsychotics, which I prefer to call dopamine blockers, because that's precisely what they do. And at low doses, they are very good anti-obsessive agents. At moderate doses, they're mood stabilizers, and at higher doses, they're antipsychotics. So I have to have this discussion with patients about a low dose atypical antipsychotic really being more of an anti-obsessive agent with a fewer side effect burden compared to a high dose. There are other augmentation strategies. Sometimes we use an SSRI, such as fluvoxamine, together with clomipramine. And genetic studies and neuroimaging studies have shown the neurotransmitter glutamate being a part of the OCD pathology, and therefore there are various prescription and over-the-counter strategies to try to block or affect glutamate. The most famous one that people probably know about is N-acetylcysteine or NAC, which is an over-the-counter antioxidant supplement that is frequently employed also at high doses to treat, to use it as an augmentation strategy in OCD, although its effect tends to be pretty mild to minimal. Next slide, please. So incomplete response is seen on a regular basis, and we always at Rogers, we're very holistic, and we always try to think, we look to evidence to see what else can we do for patients. In general, in the outpatient world, patients who are not responding to pharmacotherapy, there's very solid evidence that adding cognitive behavioral therapy, particularly ERP, to the medication regimen is very helpful. And I will discuss timing being a key component of this according to some studies. In general, patients presenting to outpatient psychiatrists frequently don't want to do behavioral therapy. So this is really geared towards more towards psychiatrists or other types of healthcare providers who are employing pharmacotherapy to really try to persuade patients to give behavioral therapy a try. Because there's very good data that patients who have received an adequate SSRI trial, and by that I mean a high dose for at least 8 weeks or longer, even those patients continue to have clinically significant OCD symptoms. And a study and other studies too have shown that ERP is superior to stress management training, which was used in the study cited above, in reducing OCD symptoms in patients continuing SSRI therapy. As far as the timing, we do tend to see greater effect when ERP is added immediately after drug response. So even when somebody responds to pharmacotherapy, if behavioral therapy or ERP is added immediately after they achieve this response, there is a greater likelihood of achieving an even greater symptom reduction if ERP is added early on and not when symptoms continue to be entrenched. Next slide.
Great. So expanding on Dr. Hadzic's comments regarding exposure and response prevention, or otherwise known as ERP. ERP is the gold standard behavioral treatment for OCD. It's very well established as being very effective. And so with that, we want to think about how do we apply ERP for sexual orientation OCD as well as gender identity OCD. I think it's important to really be able to highlight the seminal article that was written by Dr. Pinciotti, published in 2021, that delineates justice-based application of exposure and response prevention for individuals with sexual orientation and gender themes. This is the idea behind this article, is to really kind of be able to be, as professionals, more thoughtful about the ERP that we do deliver. How do we develop our hierarchies so that we are not reinforcing stereotypes or stigma? These are groups that are already oftentimes, again, discriminated against, marginalized. How do we move away from that and move towards something that is more justice-based, one that we can feel positively about in regards to affirming their identity? For examples of exposures that have, been done by many individuals in the past that may not be aligned with justice-based ERP is this idea of, let's say, somebody presents with sexual orientation OCD, and on their fear hierarchy, they might be assigned to act, quote unquote, gay. And so one might ask, well, what does that mean? What does acting gay mean? And somebody might define that as saying, you know, to talk with a lisp, or to wear certain types of clothing, or to act a very certain type of way, or to act effeminately. These are things that are not just a space. These are things that do and can perpetuate stigma and negative stereotypes, and things that we do want to be mindful about and move away from. So as outlined in her article, she does provide some guidelines in regards to how to think about our exposures. How are we going to develop these exposures in a way that moves away from these more negative stereotypes, in a way that can potentially be damaging to these groups? So some great questions is, does this exposure tokenize or out people? Does this exposure reinforce stereotypes or add minority stress? A really great question to ask oneself as a professional is, can you make this exposure a different way and achieve the same result? So going back to this example of act, quote unquote, gay, and that might then equate to acting effeminately or talking with a lisp. Is there a different way in which we can achieve habituation or experiencing that anxiety and an exposure? Does it really have to be, does the exposure have to be constructed in that kind of way? So when we think about a case example, this is a case example of Emily. Emily presents with complaints about obsessive thoughts about being transgender. She notes that these thoughts are easily triggered. Looking in the mirror when changing, taking a shower, social media or news that have topics of transgender or gender fluid individuals, seeing a female with short hair, seeing a male with long hair. She noted that she first started having these symptoms 2 years ago after seeing an ad for the show Pose, which highlights transgender characters and actors. These symptoms increase in intensity over time, and Emily rates her distress as 10 out of 10 when she has these thoughts. Emily frequently asks her parents to describe how she was as a child. Emily noted that she does this to check to see if she ever acted like a boy when she was younger. She also analyzes pictures of herself in elementary school to see if she can remember whether she thought of herself as a boy when she was a child. Emily notes that her social community is progressive and inclusive, and that she does not have any personal negative views towards the transgender community. She stated that her uncle is gay and is accepted by the family, but also notes that she is not sure if her family would be accepting of a transgender family member, as she is worried that being transgender may be considered, quote, too different. With this particular case example, things to consider are when these thoughts or these uncertainty thoughts started to arise in her mind. So based off of this, as she's currently 16 years old, 2 years ago would have been when she was 14. So one of the things to kind of think about is, what's the likelihood, or what does it mean when thoughts of potential gender incongruence occurs in adolescence or during the teenage years versus early childhood? What does it also mean when these thoughts have been triggered by watching television or certain types of shows or media or social media that may be occurring? Those are the triggers that occur. And what are the types of behaviors that she engages in? And what we talked about before is the function of the behaviors. What is the function of the behaviors that she engages in relation to the triggers and her thoughts and her beliefs? So doing an example of a functional analysis, the situation may be seeing her body in the mirror while changing. The thoughts or beliefs that may come up in her mind is, am I supposed to be a man? Because I had that thought, I must be transgender. What she might be experiencing emotionally is increased anxiety, distress, and upset. Her behavioral response is to ask questions, to ask for a lot of reassurance. Asking her parents, did I always act and play like a girl when I was a kid? Parents will say yes and provide examples. And what are the consequences of her behavioral responses? Well, her anxiety and her distress decreases. And what's highlighted here through this functional analysis is this negative reinforcement cycle. So when we go back to the CBT model of OCD, you can look at this and you can say, okay, I can probably map this onto that really well. That these behaviors are being negatively reinforced because she gets the reassurance that she needs from her parents, that she was always a girl and that she always acted like a girl. And that provides her temporary relief from her anxiety and distress. We also discussed before the downward arrow method. And this method, as I noted, is asking questions of, and then what? And then what? To really be able to identify that core fear. So so when Emily would have the thought in her mind, would I feel better in a male body? And this would cause her anxiety. Then you would ask, well, and then what? So would you feel better in a male body? Well, because I had that thought, it must mean that I'm transgender. Well, because I had that thought, if I don't know if I'm supposed to be a man or woman, then what do I even know? Then everything I ever knew about myself must be a lie. And then what? Well, that means I don't know who I am anymore and I can't trust anything about myself. So oftentimes those who present with sexual orientation OCD or gender identity OCD, it's that deep, deep, deep uncertainty of identity that really captures the distress or is at the core of their distress. It's not so much the fear of what if I'm transgender and I am stigmatized, although that could be part of it too. But a lot of times it is this, how come I don't even know who I am? How can I not know who I am? And it's that pathological doubt that you start to hear and experience when the patients are talking about their thoughts and their experiences. So when developing exposures, as noted, as highlighted, as I noted with Dr. Pinciotti's article, is thinking about exposures and developing them in a way that is more affirming or positive. So what are ways in which we could do that? For somebody like Emily, who may present with gender identity OCD, it could be things like watching trans-affirming movies or television shows, hanging a transgender flag in their room. There are these transgender bracelets or bracelets that have transgender colors on them that she could wear and walk around with. We can also do educational things. In the Bay Area, there is a center called the Rainbow Center, and it's an LGBTQ plus community center that provides education classes, connection, and is something that is really helpful for individuals to be able to learn more about the community and more about the history. And also really being able to highlight or dig deep into the core fear. So conducting imaginal exposures related to never feeling quite certain about gender identity. These can be possible examples of exposures that can be used that are more justice-based rather than ones that reinforce stigma or negative stereotypes. And now we're at our Q&A section.
Great, thank you so much. Again, now it's time to answer some questions. If you did have a question, please go ahead and use the Q&A button. It's at the bottom of your Zoom taskbar. We'll try to get to as many questions. Again, please feel free to go ahead and use the Q&A button at the bottom of the taskbar. If we do not get to your question, please feel free to send an email to webinars@rogersbh.org and we'll follow up with you at the very end. Go ahead and ask our first question here. What are some compulsions that may present in SO OCD or in gender identity OCD?
Checking behaviors is something that's very common, and that could be checking, for example, if somebody has sexual orientation OCD. So checking to see if somebody's male, then maybe are they attracted to other males? What if they looked at pictures of other males? Do they feel something? Do they feel attracted to them? Do they feel sexually aroused by them? Reassurance seeking is also a very common compulsion as well. Asking questions, saying, you know, with the case example of Emily, where she's asking her parents, how did I act when I was a child? You know, what did I look like? What are the things that I enjoyed? those who have OCD and who may recognize that some of these are reassurance-seeking questions may pose the questions in a way that don't seem obviously reassurance-seeking. So they may say something to their parents like, "Tell me about my childhood. Tell me a little bit more about that." Or, "Can I see some pictures of how I look like?" Some pictures from when I was in elementary school. But they might use those pictures as a way to kind of analyze and figure out, was I, what did I think about then? How did I act like then? Was I acting like a boy or was I acting like a girl? So these are the types of things that you might see in OCD.
Great, thank you so much. How would you target mental compulsion of someone with gender identity OCD?
So with mental compulsions, it's like any other types of mental compulsions, can be quite challenging. So there are different ways that we can address mental compulsions. It could be doing things like messing it up on purpose sometimes. And again, it depends on what kind of mental compulsions they have. So if their mental compulsion is to say things to themselves in a very particular way, then they can mess it up. They can do it backwards. They can undo the compulsion, if you will. If their mental compulsion is some type of self-reassurance, no, you're not actually gay, you know that you're straight, and providing examples of why they might be, rather than that, combating it with, I may or may not be gay, and this is something that I'm uncertain about, and I may never know, and I may never have certainty around it. So you can have things or different types of interventions readily available for the individual when those mental compulsions occur.
Thank you. The next question, how do clinicians control their own bias when conceptualizing or creating exposures?
So I would say it depends on each individual clinician, whether it's a solo practice or a group practice. At Rogers, we frequently, not frequently, we always consult colleagues and talk to each other about exposures. And we also try to be very conscious of not reinforcing any stigma. But as far as solo practitioners, I think certainly it depends on their worldview and how they approach exposures, and how mindful they are of their own bias. I don't know, Dr. Park has more to add.
No, absolutely, Dr. Hadzic. The professional consultations, seeking out peer supervision, discussion of cases. I think that as clinicians, we are oftentimes trained to be really thoughtful about what we're bringing to the room, how are our personal experiencing coloring the way in which I perceive this individual or perceive this particular case. Ideally, for those who may not agree with the LGBTQ plus community, if the individual can have acknowledgement of that and recognize that perhaps this is a group of individuals that they might not be best suited to work with, and to be able to refer out. Again, that requires a certain level of self-awareness and experience for them to be able to do that. But as Dr. Hadzic very much kind of aptly noted, it does depend on on the individual clinician's worldview in regards to how they might manage that situation. But really, at the end of the day, it's going to be a lot of consultation, peer supervision, and self-reflection.
Thank you. This next question here is, what are some examples that a doubt about sexual orientation or gender identity is ego dysonic? The violence against these communities is real. So what would make sense? That is there a lot of fear or apprehensive about their authentic self?
That's a really wonderful question, because it's so true. As we talked about throughout the presentation, about the very real social discrimination that these groups experience, and the very real violence that they may be at risk for. That's where, as we had kind of briefly touched on, that ego dystonic piece does come out, is that there could be internalized homophobia, internalized transphobia, that may cause an individual to really react negatively to any types of thoughts or ideas that they might be either gay or lesbian or transgender. And it's challenging. And as part of the assessment phase, that's why it's important to really get a clear assessment of their personal views, their background, their cultural views, and to get a sense of, how accepting is this individual. If it weren't OCD, would this person accept themselves for how they are? Is this something that would cause great distress? And what are the variables influencing that?
And I'm just going to add real quick, sometimes even for the most experienced clinicians, and certainly at Rogers, we have such a wonderful clinical body. We really don't know until we start exposures. And that if the patients tell us that they like, sometimes we have them, watch a movie or a TV show where there's a gay couple kissing. If they tell us that that's actually something that they're drawn to, then there's clearly an egocentric nature to that. And then we have a discussion with them about, is this OCD or is this something else?
Thank you. That's a good explanation. Are there additional educational resources, maybe such as journals or books, that you would recommend to learn more about gender identity development?
So we listed some resources, and there's currently not a single book that we recommend. There are these resources have been vetted by major professional associations, and that's our first line recommendation.
Okay, thank you. And I think we have one last question here. Again, unless someone else would like to ask any other questions, you can please feel free to put that in the Q&A button. Another question here is this a form of purely obsessional OCD?
It can depend. I think that in a lot of situations, people might mistake it as a pure OCD because the behaviors or the compulsive behaviors are maybe a little bit more covert in nature. Oftentimes when that occurs, what we want to look at are potential avoidance behaviors. So somebody might say, no, I don't engage in any compulsions at all. I don't have any rituals. I don't ask for reassurance. I don't check. I don't do any of those things. But then the next line of questions then can be, are there places that you don't go? Are there things that you don't do that you normally would because you're trying to avoid certain types of triggers? So in any type of situation where we might consider there to be a pure O, I think rather than taking it as face value, it's important to do an ongoing assessment of different types of behaviors that the person or the individual may be engaged in to be able to reduce their anxiety artificially.
Thank you. As we wrap up here today, what would you say that are the 3 top takeaway messages that you'd like the audience members to remember from this talk today?
Maybe we can both provide a couple.
Yes, thank you.
One of the things that I think is most important as professionals is to, for those who might be treating OCD in your practice, is to be very mindful of how you're constructing your exposures. What are the things that you're thinking about as you're constructing them? And really going back to that article, and as well as that one slide of asking yourself these questions of, am I outing someone? Am I tokenizing someone? Am I reinforcing some sort of negative stereotype as you're thinking about how am I going to treat this patient in front of me?
That's a really, really good point, very salient. I would say on my end as well, I want, one of the takeaways is we should not be afraid to ask questions, but I do think that building rapport and asking them in a sensitive way is really important. But a lot of things end up not being revealed because we're not asking questions. So it's a very delicate balance of not wanting to precipitate any emotional distress in a patient. But one clear way to try to build rapport is to ask a patient what pronouns they use. It's one of the first things I ask my patient when they come into my office. And it can really, for those who are gender incongruent, it can really be like this first step that makes it clear to them that their clinician is sensitive to their gender incongruence.
Thank you. That was a great wrap up. If you do have any questions that you think about afterwards of the presentation today, you can always feel free to email us at rogersbh.org and we will follow up with you. The entire fall lineup for 2023 webinars is published on the events section at rogersbh.org. Please bookmark that spot so you can go ahead and check to see what is upcoming. We will have a November and a December webinar that we'd love for you to tune into. So please go ahead and check that out on our website. Our outreach representatives are looking forward to connecting with you to learn more about your practice and help you understand the treatment options that are available to you at Rogers. Before we conclude, I'd like to ask our presenters to share some of their additional resources. I see they already have that up on the screen right now, where we can get some additional information. So that wraps up our webinar today. I'd like to remind the participants, just go over some of how we get our information and credits. Within the next 30 minutes, you will receive an email link into your personal dashboard at CE Go, and where you'll be able to access all the PDFs, so the PowerPoints of the presentation today. You'll be able to do an assessment measure and complete a list of references. Those of you who did meet the time requirements of the webinar today from start to finish, you'll be eligible for CE credits. You'll also get a link to complete the evaluation. That will be most important, to complete the evaluation to download your CE certificate then. If you have any questions about the follow-up email, please go ahead and contact support@ce-go.com. On behalf of Rogers Behavioral Health, we thank you so much for tuning in today's webinar. We thank our presenters who did a great job today, and we look forward to partnering with you and helping support your patients. So please reach out if you have any questions, and thank you again for joining us today. Thank you so much.